I'm very proud and honored to introduce our series, Let's Talk About. Today's program, Let's Talk About Midwives and with Midwives. My name's Dawn White, I'm Senior Director of Marketing. I'm very honored to introduce this series today and program. This is brought to you by UW Medicine, the marketing team, as well as our panel of experts from the Center for Women and Children, as well as co-sponsored by our publication, Right as Rain, that many of you may subscribe to. So today, before I hand this over to people, I just want to give people just a reminder. This program is being recorded and will be sent out to all participants, as well as our people who have registered in advance and weren't able to attend today's conversation. That will come out to you within 2 to 3 days as well. Few rules of the road. This is a live session, as you realize by my introduction of my lovely dog. We are going to be taking live Q&A questions. At the bottom of your screen, please submit all of those questions that you may have, and our panel of experts will take those programs and either respond to them during the program, as well as will provide ample opportunity at the end of our program for a Q&A session. And with that said, I am honored to hand this over to Mary Lou Copus, who will be moderating and conducting and recording today's panel conversation. So Mary Lou, thank you.
Thanks, Dawn. Hello, everyone. Welcome. Thanks for joining us. So we're happy to be part of this series, and we've got a great group of midwives here at UW Medicine, and there's a sampling of them here. And so there's 4 midwives on your call, including me. I'm there at the bottom, and we're going to introduce ourselves. We'll start with Hannah.
Hi, everybody. I'm Hannah. I am part of the Northwest Midwives Clinic, and I'm happy to be here today. A little bit about my road to midwifery was I was at a birth when I was 19 that kind of kicked off my path, and I have just my passion for healthcare that is holistic and inclusive and respectful has just evolved over the years and led me to where I am today. And I find the work really rewarding. I think it's a really special opportunity to be present with people in their most vulnerable, life-altering moments. And I love practicing in a model of care that emphasizes individualized care and shared decision-making. And yeah, I'm happy to be here.
Cool. Where'd you go to school, Hannah?
University of Pennsylvania.
Cool. I knew that. I was just leading her.
East Coast transplant.
Mary?
Hi, everyone. I'm Mary Bowles-Holder, and I am a certified nurse midwife and a psychiatric mental health nurse practitioner. I'm a tried and true UW graduate and graduated a number of years ago from the University of Washington with my graduate degree, and more recently with my doctoral degree as a psychiatric nurse practitioner. I too, interestingly, kicked off my midwifery path at the age of 19 when I too was at a birth at the age of 19, and I didn't know that about you, Hannah. That's so great. And then I feel like midwifery actually really came to me. I was asked to attend a number of births and was a home birth midwife to begin with in my 20s, and then went back and got my formal education in nursing and then midwifery after about a decade, and have been practicing at the Northwest Clinic with Hannah and Mary Lou. Previous to that, I was actually practicing at Mont Lake, so I'm familiar with both practices. I love what I do. As many years as I have been doing it, it feels like it's always fresh and always new, and it feels like such a privilege to do the work that I'm doing, being witness to women at their most magnificent moment in life. The work is always new and fresh as well, and challenging at times, but most particularly enlivening and enlightening. So it's a pleasure to be with all of you today, and I look forward to talking more. Thank you.
Great. And Heather?
Hi, I'm Heather Ranney, and I'm one of the midwives that's restarting the practice at Mont Lake. Mary Lou and actually were nurses together here before we were midwives, so we have a good long history. I feel like UW is my medical home, so I'm really proud to restart the practice and care for women here. I started my midwifery journey really when I had my own babies, and I recognized that it was a really important role to play to advocate and to educate and care for women and families and all of the circumstances that come with pregnancy, but also with just women's healthcare in general. So I also love what I do. We're very fortunate to all work together and have such a fantastic group. So we look forward to answering questions.
Great. And I'm Mary Lou Copus. I'm with the midwife group at Northwest, and I've been here coming on 10 years. And I'm also definitely a product of UW and UW Medicine. I kind of came to midwifery a little bit later in life. I was probably 30 before I really realized what I wanted to be when I grew up. And I thought I wanted to be a scientist, and I studied biology, and I started a graduate program in biological oceanography before I realized that I really didn't want to be a research scientist, that I really wanted to do something much more practical and applied and working with people. And so I did some organizing work for an environmental organization and realized that I really liked working with people and motivating people, and I had to figure out kind of how to mix those things together, my love of science and physiology, and I don't know, somehow midwifery came to me, and the more I dove into it, the more interesting it became. So I actually wanted to be a midwife before I had my babies. And then it took a while to become a midwife because I started school, I started having children, I had 2 children, I spent several years with my children, and then eventually I finished school. But I did my nursing and my graduate degree at UW. I worked as a labor and delivery nurse, where Heather and I worked together at University of Washington, which was a great place to be a nurse because it's a teaching institution, and I just learned a whole lot. And then I worked at Valley Medical Center, which is also in UW. That was my first midwifery job. And then I came here, where it really feels like home. And I've been here almost 10 years. And I guess what I love most about this work is just the people that I get to know and the families that I get to meet. And when you work in healthcare, you really meet a broad range of people that you probably wouldn't meet in your average social life, and just getting to know them and getting to hear their stories and what's important to them, and really advocating for them to be in charge of their healthcare and to learn about their bodies and how their bodies work, and sometimes sitting with them through difficult challenges and difficult things, and helping them with that is just really satisfying work. It's hard, but it's very satisfying. And I love my partners, I think, is probably what makes my job most, next to the patients that I work with are my partners. So we're a good team. So those are introductions. And then each of the midwives is going to give you a little bit of background about, because we're here to tell you about midwifery. So here's Hannah.
Hi again. I think it's a question that gets asked a lot, is what is a midwife? And a midwife is someone who's a trained healthcare professional, and we specialize in pregnancy, birth, newborn care in the first month of life, breastfeeding, gynecologic care, and even primary care. We have a segment of primary care in our education. And I think that it's common for people to focus on the pregnancy and birth scope of our job, but we actually see people from puberty all the way through menopause. And I particularly find that part of our care really rewarding, the gynecologic parts of the care. There are different paths to become a midwife. Licensed midwives and certified nurse midwives have different training paths. Certified nurse midwives are trained in both nursing and midwifery, which is a graduate education. The majority of certified nurse midwives practice in clinic and hospital settings, but we have the ability to practice in any setting, including home and birth center work. And licensed midwives, it's also a graduate education without the nursing component. And most licensed midwives practice in out-of-hospital settings. Sorry?
Community birth settings.
Community birth settings, yes. And the philosophy of care is really individualized, holistic. We consider pregnancy and birth to be a normal physiologic process until proven otherwise. And I would add just shared decision making and really advocating for people who are in our care to feel empowered to make their own informed decisions.
For sure. Thank you. And Mary?
So this is oftentimes a question that's asked to us as midwives is, how is a midwife different from an obstetrician? And midwives do have a different path of training than that of a physician. We usually, as certified nurse midwives, start out with a nursing degree and then go on to get a graduate degree, whether it's a master's or a doctoral degree in nurse midwifery. And then we have a governing body, the American College of Nurse Midwives, that oversees our certification and current education. The similarities include that we all see our patients in a clinic setting, and we have full prescriptive authority to order medications and lab work, do admissions into the hospital setting, and then we manage a woman's birth process through the postpartum period, and oftentimes see them for their ongoing care, well women care. One of the differences that I would say in terms of kind of the path of values between midwives and, say, physicians is that midwives are really attuned to see birth as a natural physiologic process. And obstetricians and medical doctors in general are just trained in the field of more pathology. So obstetricians deal with more high-risk pregnancies, and though some midwives do deliver twins, it's usually in the realm of obstetricians to manage multiple pregnancies and pregnancies with complications, whether it be hypertension or diabetes or any other more complicated or obscure aspects of a woman's or a baby's health. Midwives, part of the value that we have as midwives is to really get to know our patients and spend as much time as we can to really cultivate relationship with them, both in the prenatal setting and as well at the time when they come in to give birth. Our visits are oftentimes longer than those of obstetricians. Typically midwives, their practices when they're in a group setting is, the hope is that you get a chance to meet all of the midwives in the practice throughout the pregnancy so that we know you and you know us, and we have a sense of each other, and we have a sense of your lives as well. So the time that we spend with you in your prenatal care is a lot more than just checking in with the physiologic aspects of the pregnancy itself. We want to know about the psychosocial, the emotional, even the spiritual aspects of your time as you transition to motherhood. And so, what I can say is that for me, I see the prenatal care and the transition to birth as, we have this opportunity, this window of time with women that is intimate and profound, and really quite a privilege to walk the journey with women as they become mothers, and for all the people involved as they transition to welcoming this new little being into the world. So, as midwives, our hope is that we make that transition as wholesome and as fulfilling as possible.
Thanks, Mary.
Mm-hmm.
All right, Heather's going to tell us about common myths.
Yes, this is a good one. I feel like this is a question that comes up all of the time when I first meet families, is they'll say, well, is it okay if I have an epidural if I choose a midwife? Is it okay if I am worried about some aspect and I need different medication, or I need you to do something other than just what they kind of view as very hands-off care, and that's absolutely up to whoever is the birth partner or the birth person. They get to choose their journey. I really see myself as a guide or an advocate there to educate and help make decisions, but really to facilitate the birth that you're hoping for. So if your perfect birth is to come in and have great support and great pain management, we absolutely support that. So the myth is that midwives only deliver at home, and really only in a natural, unmedicated way, but really midwives are here to support all birth. We're here to listen to what your birth wishes are and what your birth story is, and do our best to help you get there. And same, so if you feel like you might have a more complicated pregnancy, or there's something that's making you worry or feel like you have a higher risk, then you think that maybe a midwife is not available to you. But in actuality, we're specialists in physiologic birth, but we're also educated to manage some complications that occur. And especially here at UW, we're partnered with a phenomenal healthcare team, which allows us to do some collaboration. So not only can we really help guide you in physiologic birth, but if something comes up along that process, we're educated and able to also manage some complications. We talked a little bit about midwives only doing pregnancy and birth, which, as you know from hearing us talk, all of us really love the idea that we get to care for women throughout their whole lifespan. We do absolutely love being with women during their prenatal and their childbirth experience and postpartum, but I think we all love to see those women a year later for their well woman exam, or to check in if something changes. It's a relationship that's built, and we love that it can continue throughout. Midwives and doulas are not the same, but we work very well as a team. We have a similar philosophy. We're really there to support and educate and care for you in a holistic way. The difference is midwives are trained clinically to take care of the more medical part of your birth experience, whereas doulas are there to really care for your emotional and kind of physical support, helping you learn about coping mechanisms. So a little bit different, but we do work beautifully as a team, and we have similar goals.
Cool. So it sounds like there's some overlap between what doulas do and midwives do, although midwives are doing a whole lot that doulas are not.
Yeah, doulas are a complement, I think, to the way that we view birth. We love it when families build up this beautiful support system. We're part of that in terms of really managing and educating and guiding the clinical side of your birth process. Doulas generally help kind of glue together the emotional support and some of the labor and coping. So altogether, it's a pretty great team.
Cool. And I love how you mentioned the collaboration with obstetricians, and not just obstetricians, but high-risk specialists. And that's one of the things that I think we all love about working at UW Medicine, is that we get to work with some world leaders in research and care, and we get to consult with these people and ask them for their advice on our patient. And that's a really nice. It's really nice to be a lower risk provider but have such access. And during this whole COVID thing, it has just been amazing to have access to people who are leading on all the information that's coming out in COVID and pregnancy in a lot of ways.
I think the other fantastic part about that is they are very supportive of midwives as well. They really value and understand our part of the healthcare team. And I have only found amazing support working here and being with the UW physicians. And I really feel like women get a phenomenal opportunity to have great healthcare in this team.
Yeah, and I think both of what Mary Lou and Heather, you said, answers a question that's in the Q&A asking about what the care team looks like in the hospital. So someone asked, is it possible to work with both a midwife and a primary care physician for the birth? Or do you choose between one or the other? And usually if you're choosing midwifery care, we are your primary care provider for the pregnancy and the birth, but we also collaborate with obstetricians, and we can include them in the care as needed and as appropriate. And there was another question asking about having a doula if you have a midwife or an OB, and you can have a doula whether you have a midwife or an OB. We welcome doulas no matter who your care provider is.
And then I have a slide talking a little bit about labor and birth care with a midwife. So, or I guess, and prenatal care as well. So during prenatal visits, we're doing some monitoring of the physiologic aspects. We're seeing how your baby's developing. We're ordering an ultrasound to look for, make sure everything is developing normally with your baby as needed. And we're addressing sort of common discomforts and complications in pregnancy. And occasionally we're dealing with uncommon complications in pregnancy. And occasionally we'll have patients who are having a visit or 2 or 3 with one of those high-risk doctors, but they're still able to see us for the normal aspects of their pregnancy and to give birth with us, which is nice. Although most people who come to midwives really don't need to see a doctor through their whole pregnancy and birth. I'd say the most common reason that people end up meeting an obstetrician and needing an obstetrician is if they're in labor and there are complications such that they need a C-section, and that tends to be about 1 in 10 people. So the other thing we're doing in our prenatal visits that we find just as valuable as that other stuff is, like I think Mary alluded to, how we're getting to know you. We're getting to know you, your family, your partner, what are your wishes, what are your values, what are you afraid of, what are you excited for? And all of that is part and parcel of the journey to growing a family and becoming a parent and or adding to your family. And every journey is different. Even every pregnancy within the same family is different. So so that's laying the groundwork that's going to help us when someone's in labor and birth, and we need to have a good trust relationship, and we need to know what's important to you so that we can take good care of you. So that's an important part of what we're doing in our prenatal visits. We generally, because we support the physiologic process, we prefer to let labor start on its own and progress on its own. If we need to, there are circumstances like someone has preeclampsia. That's a really good reason to induce your labor, because the risk of continuing your pregnancy is probably more than delivering at a certain, than waiting. I'm sorry, than giving birth then at a certain point. So we can use medications because we're in the hospital. So we can use medications and the same things that OBs use to induce your labor when we need to, but we would really, for most patients, we're patient and wait for labor to start on its own. And there's a wide range of normal and progress in labor. So we can be patient in labor progress. If we need to augment the process, we can do that, but we try. And I would add that part of what helps labor go along normally is people feeling safe, secure, comforted, cared for, and the environment. We talk about in birth, we want to keep things generally kind of quiet, calm. We try not to disturb the laboring woman too much, particularly when people are in natural childbirth. That's kind of an altered mental state, and we try to encourage people to be in that state and support them, but not try to make them think too much and pull them out of it. So the things that we talk about in terms of making people comfortable, playing some music, dimming the lights, all that, those are not just niceties, they actually do help the physiologic process work. And you progress in labor better if you don't have a lot of anxiety going on. And that's one of the things that can happen in the hospital. And so we really try in the hospital to maintain a calm environment and only bring in all those other things that we have around us, the resources to deal with emergencies and complications. Just bring it in as needed and have it there waiting in the wings, but not staring in the face. So we're not, we're not running an IV if you don't need it. We're letting you move around and you don't have to stay in bed. We're letting you eat and drink. We're letting you get in the tub, and sort of following the natural rhythm of the labor is important. We encourage people to do childbirth education. Most people with their who've given birth before don't need that, but especially with the first baby, not everyone, it's not a requirement, but we definitely encourage people to do childbirth education because there's more that you need to know about the process and preparation. And there's also some camaraderie that happens when you're in a class with other couples or people having babies that can really be a bonding process, which right now is happening through Zoom meetings like this. But someday, hopefully, we'll be back live again. And then we do ask you to write a birth plan or preferences. We'd like to, not everyone does, it's not a requirement, but most people at least write down, who's going to be there with them, what do they think they want to do for comfort, where are they on the continuum of, I want an epidural as soon as I walk in the door to, distract me and try to talk me out of it if I start talking about an epidural. Where are you on that continuum, and what's important to you? So we like to know that. And then some of the things we can use for comfort in labor. Generally when you go into labor, you call from home and talk to the midwife, and we may have a conversation a couple of times while you're doing your early labor at home, deciding when it's time to come in, and there are a lot of things that we factor into that. And then when you come into the hospital, we meet you there. You also have a labor nurse who meets you there, and we assess the baby, we see how you're doing, and if it's active labor and time to be admitted, we can do that. And then for comfort measures, there's everyone's probably heard of an epidural. It's kind of a gold standard of pain relief. If you're really just exhausted and you just hating it and you just need to sleep, epidural is the way to go. They're anesthesiologists 24/7, both our locations, and they don't care if you're an OB or a family med or a midwife patient. If you want an epidural, they'll come give you an epidural and maintain it for you. But we have a lot of other things that we can do. We have nitrous oxide that people sometimes use, which is just a mask that you breathe that can kind of help people. It does not give as much pain relief as an epidural, but it can help out. And then we have a lot of people who are using hypnobirthing and deep relaxation techniques, positioning, massage. People use like TENS units, which is like an electrical stimulation on the skin that can help a lot, particularly with back labor. Definitely being out of the bed a lot of the time can be helpful. People are usually more comfortable in positions other than lying on their back for sure. But sometimes, you alternate rest with activity. We have some lovely birth tubs at both our locations that people labor in, and water immersion can be very helpful in labor. I call it the poor man's epidural. And a lot of people find that really helpful. And then we have a lot of space in our rooms so that we can, kind of spread out and do different positions. We actually have some like gym pads now that we can put on the floor, and people can do different things. And likewise, when you're pushing in labor, we don't want you lying flat on your back for the most part. People usually, they may push in several positions and then deliver in a position that seems to be working. So there are a lot of options. So we kind of go with what's happening.
One of the questions in the chat was about nitrous oxide and when is it effective. I responded a little bit, but I love nitrous oxide to kind of connect or bridge labor places. So sometimes if you're just moving into really active labor and you just need a little bit of catch-up time to cope and find a new rhythm, nitrous oxide works beautifully for that. It's fantastic when you're transitioning because you've learned to cope with active labor and now you're transitioning to this place where things are a little more intense, and nitrous oxide works really well there. It can also work really fantastic if you've had an unmedicated delivery, but then need a bit of a repair. It can work really well to help cover some of that short space of time as well. So I think Nitrous has fantastic options. It works really well, and it works great actually as a bridge in labor.
Yeah, and I think one of the things people like about Nitrous is that you're not stuck in the bed with an epidural. You're in the bed. You have a lot of lines and attachments on you once you have that. And with the Nitrous, you can kind of pick it up, use it when you want it. You have control. You put it down when you don't want it, and people tend to use it for a while and then put it down and then do something else and then maybe go back to it or maybe not. Yeah, and I think it can really help get over a hump. It has. It's interesting. It's very individualized. Some people get a really good relief from it, and some people it doesn't seem to do much at all. And it also has a little bit of a anti-anxiety effect for a lot of people. So it kind of just calms you when you just kind of, like you said, that part of labor where you just like feel like, I don't know if I can do this.
Yeah.
So it's fast. You don't have to like set it. You just like, here's the mask. It's ready. Try it out.
We have a question about possible side effects from nitrous oxide, and I would say the most common side effects that I've seen are dizziness and nausea.
Mm-hmm.
I've also seen some people who are a little bit claustrophobic with holding a mask over their mouth and their nose. I would say the dizziness usually passes once you get used to it, and I don't see a lot of nausea. I don't know what everyone else's experience has been, but that's kind of listed as one of the potential side effects. And I haven't really witnessed that. I've witnessed people being nauseous just because of the labor process itself, but not specifically from using the Nitrous. And if there is significant nausea, whether it's from Nitrous or just from the labor process, we do have very fast acting medications that can help alleviate that.
One of the additional benefits of nitrous oxide too is that it clears the system really quickly, and so within seconds it's out of your system. So it's very low risk intervention that women can use. And I actually think one of the nice things about nitrous oxide too is just the actual mechanism of the deep breathing of the nitrous oxide is there again a really good technique and strategy for coping to just keep your breath moving. And so I actually find that nitrous oxide has that additional benefit without the medicine even a part of the picture.
So there's a question here about using and I think somebody mentioned this question about, can you have a primary care physician and a midwife? Generally you choose one team or provider who's going to be caring for you primarily through your pregnancy. And then you may consult with another provider as needed. But generally there's somebody who's what we call the OB primary care provider. So that could be a midwife, or it could be a family medicine doc. They actually some of them do birth as well and pregnancy, or it could be an obstetrician. And so although we work closely with obstetricians in a situation where a patient of ours needs, like say a C-section is the most common reason I'd say, at that point, the obstetrician, takes over care, does a surgery. The midwife may scrub in and assist with the surgery and continue to see you, care for your baby, work with you on breastfeeding and some postpartum care. But the OB takes over. So generally, there has to be somebody who's in charge of your care. And so it's not usually both at the same time. And sometimes, and I don't know if this is what you're alluding to, but sometimes people ask, well, can I just have an obstetrician just in case? Like, I just want a midwife, and I want an obstetrician just there in case. And so an obstetrician can come in the room if needed, but there's really nothing for them to do if they're not needed. And so, like I said, the vast majority of our midwife patients don't end up needing or meeting an obstetrician, but they're great. If you need them, we can bring them in. And there's no delay in dealing with an emergency if you have a midwife. And there's actually some really good evidence. There are a lot of research papers out there on outcomes of care with midwifery, outcomes of care in labor. And for low-risk women, the outcomes for moms and babies are at least as good as with obstetricians. And there's some evidence that the interventions are lower, that use of epidurals is lower, use of labor induction and C-section rates are lower when people are cared for by midwives. And also there's some evidence on perineal trauma is less. Tearing and lacerations are less with patients cared for by midwives.
Just to add a little caveat to that too, oftentimes people who have a primary care provider who they see on a regular basis for whatever might ail them outside of pregnancy, they might opt to see them, for some kind of urgent care issue during their pregnancy. And we like to collaborate when we hear something else that's going on with someone outside, maybe separate from the pregnancy, but during their pregnancy. It's helpful for us to have that information so we're all kind of kept in the loop. This is also the case with, say, someone who has a thyroid issue and they see an endocrinologist for their thyroid management. Though we do manage thyroid function in pregnancy as midwives as well, we work well and collaboratively with other providers who might also be a part of your medical team.
That's a good point. There's a question here I direct towards Heather. It says, it seems the midwife practice at Northwest is larger, something popped up on my screen, is larger and more mature than at Mont Lake. If I'm delivering at Mont Lake, can I have a midwife as my provider?
Absolutely. The practice actually, no, the history actually of midwives at Mont Lake is that there was a thriving practice here for many years. And in 2011, when Northwest and UW became affiliated, they felt like maybe the midwife practice was better suited to the environment of Northwest. And so they transitioned up there. There were several years in between, I think 9 actually or more, where there were no midwives at Mont Lake. But what we recognized was that women really want access to midwives at all locations. And so even though it seems like we are just beginning, we're actually continuing that legacy of midwifery here at Mont Lake. So we have a really great, strong foundation that a lot of these ladies laid for us, actually. And I think that's why we have such great collaborative care with our physicians and our residents, is because there was always such a great feeling and a great level of healthcare that came from the midwives before. And so we are just picking up that ball and running with it still. So you are absolutely able to have a midwife at Mont Lake, and we're happy to have you.
It does feel like we've kind of come full circle with regards to having the practice there at Mont Lake and then transitioning to Northwest, and then now you guys opening up this practice again at Mont Lake, and it feels really wonderful to have that contribution in both campuses.
For sure. And in more locations now, the expanding into more clinics where you can have access to a midwife. Sorry, I'm looking at the questions. It's possible where we answered that one. And then we had some people who entered some questions ahead of time. And one was, I'm 35 weeks and thinking of switching to midwives. Will that be too late? Hannah, do you want to handle that one?
Sure. It's not too late. We don't really have a gestational age cutoff for transfer. Ideally, we would love to have a few visits with you in clinic before you give birth to get to know you and provide some care. But I would encourage you to call and inquire about an appointment, and we would be happy to see you and make sure that we're the right care providers.
Yeah, I always tell people that, I've talked to a lot of friends who said, well, I just stayed with my provider, because it's, whatever, switching seemed hard. And whether it's with us or switching from us to another practice, I mean, you really need to trust who you're working with, and you need to, there are a lot of options in Seattle. So you should give birth with someone you really trust and feel is, got your back and going to take good care of you. And if you don't feel comfortable, then it's worth considering switching. I say the same thing with pediatric care. There's a lot of options, and you start, with one and you're happy, great. But if you're not happy, switch. There's nobody takes offense when you switch. People switch care a lot.
And keep in mind, this is your experience, not ours. So we're here to serve you.
That's a good point.
Mary Lou, there's a question about VBAC, or vaginal birth after cesarean, and who is equipped to care for people who've had a cesarean section and would like to have a vaginal delivery. And I'm happy to say that the Northwest Hospital midwives will be able to offer vaginal birth after cesarean starting in September. Midwives are trained to take care of women who've had a cesarean section and would like to have a vaginal birth. That is part of our education, and we are happy to have that option and that privilege. It will be for people who've had one prior cesarean section. They can opt to have a vaginal birth with a midwife at Northwest Hospital and at Mont Lake as well, Heather?
Yep, we currently accept patients who've had a prior C-section.
And another question was, how do midwives approach an IVF pregnancy? Is it any different? And I can say something about that if you guys don't mind. Generally, no matter how much work and effort it took and expertise it took to get you pregnant, once you have a viable intrauterine pregnancy, you're not as high risk as you felt when you were going through that process. And having friends who've gone through that, I realize how difficult that journey can be. And sometimes transitioning from a weekly visit with your fertility provider where you're getting an ultrasound every week to midwifery care, and you come and people are like 8 weeks, and we're like, great, we'll see you in a month. I'm like, what? It's how can this be normal now? Sometimes that can be a little bit of a shift for people. But generally it is a lower risk pregnancy. I mean, there's some research on very tiny increased risk of heart defects, but that's something that you screen for in pregnancy in any case. But generally those are, we consider them, and OB community considers them as lower risk pregnancies once you're pregnant. We do recognize that transition can be challenging, and sometimes people do need to come in more often just to check, hear the heart tones. 4 weeks is too long for them to wait, and we can accommodate that. It's your pregnancy, and it's your body, and if you want to come in and hear your baby between visits, by all means, come on in if that's going to give you peace of mind. What are some things to think about when deciding about home versus hospital versus birth center? I wonder if Mary might answer that since you've done home birth.
Yeah, I'd be happy to answer that. I can fully appreciate why people would choose to do a home birth. It's an intimate and very family-oriented kind of experience. And I think most particularly in this prior year with COVID, there have been some people that have wondered if home birth would be a better option because of some of the restrictions that have been placed upon us in the hospital setting. But I think that ultimately what it comes down to, and this is what I have actually learned, and as a home birth and a hospital birth midwife, is that ultimately what I think every woman should strive for is getting clear about what it is that makes them feel most safe. I think that when a woman feels safe in whatever environment she's in, that she will do her finest work. And sometimes that's in the hospital setting where there is accessibility to the facilities of an operating room, and there's more resources around and more help around them. And sometimes that's in a home birth setting. Now, there are some women that would try for a home birth initially and then transfer into the hospital. And in both of our campuses, we offer that service as well. And then there are also women who might think that a home birth is what they want to do, and in actuality decide that they want to do a hospital birth. Any of those things are reasonable things to consider. I think it can be challenging sometimes to make that transition from a home birth to a hospital birth setting. And I think that there are some advantages and disadvantages to both. But ultimately, I feel, one has to come back to where they feel most safe and most held to be able to do birthing work.
Mary, I would
Some
love to
people
add
would-
to that, one of the things I appreciate so much about our practice at Northwest is that we have the ability to accept community birth transfers. So it's been a nice experience to help make those transitions when they need to happen as smooth as they can be and continue midwifery care even though the setting is changing.
Absolutely, yes.
And then I would just add that there are some, you need to be fairly low risk to deliver in a community setting. And that's why planned home birth is relatively safe, is because women are screened, patients are screened. So something may come up where, you no longer are a candidate for community birth, such as like high blood pressure or something like that. So I think one of the things I would just add, sorry, I'm going to add one thing. When you're in a community birth setting, oftentimes there's fewer midwives, or maybe 1, 2, or 3 midwives to meet. And so sometimes that can feel more intimate. Sometimes they're even solo practitioners where, unless they're sick or out of town, they're going to be there at your birth. So that can be a really nice experience for people. But particularly with a first baby, there's a good portion of people who will transfer for whatever reason. And so then you have to shift and have a different care provider that you don't know. And so that is the downside, I'd say, of a planned out of hospital birth, is that possibility of transitioning. And then I'm going to send this question to Heather. Is the Mont Lake midwife practice similar to Northwest, where you meet with all the midwives throughout your pregnancy, or do you have one primary midwife?
We tend to actually have our own panel of patients. We are happy to meet each other's patients, but we do tend to just fall into our own panel of patients. Some of that is actually just a location. One of our midwives, Erica Weekend, is at South Lake Union. Sarah Chandler is at Ravenna. I am at the Mont Lake main campus, and so just by nature, it's if you come to Mont Lake, then you'll see me. But we do have telemedicine visits available, so you can meet us all. And I think we enjoy and appreciate the group model, but I think we also like some of that continuity in our care as well.
And I'd say people can choose what they want with the Northwest group, but generally we're a group practice and we share everybody. And most people, they want to meet who's going to be there. So I think there's definitely about, there's benefits to having a primary midwife for sure. And then there's also benefits to, having met them all.
Right.
There's another question here. There's so much fear-mongering info on seemingly reputable pregnancy websites. Where can you find answers to pregnancy questions?
Call your midwife.
I was going to say, ask your midwife.
But that is true. There's, we have such access to information online, and it's a double-edged sword because we have access to good information, and we all have access to inaccurate information, and also generally, whatever is more dramatic and emotion wrenching is going to be shared more. So we do have. That's something I think as midwives that we try to fight, is that that culture of fear around birth. On television, there's always somebody screaming, and when they're giving birth, and it doesn't really show accurately. And a lot of people, hear all kinds of scary stories when they're pregnant. And I definitely talk to patients who are intentionally finding the good stories and trying to surround themselves with the positive stories and avoiding the negative ones.
Definitely, in terms of that, I think one of the things that we all strive to do is create a safe space. Of course, if you're going through something brand new, you're going to find lots of times in that pregnancy where you feel uncertain or you feel scared, and you may read stories that then kind of make you feel even more fearful because you read it out there online. But I think every time you come in and you have questions and we talk through things and you learn to be in that safe space and work through them, then as we get closer to birth, you feel more and more confident that your process is going well, and that if something did change, that you have the right care provider to take care of you. So it's an important part of what we do, is to create that safe space.
For sure. And there are a lot of good books and websites out there, and we do have a list of resources. At the end of our webinar, we're going to post that. We have a slide of those. And I think it was mentioned at the beginning, this webinar will be recorded. And so if you register, you will get the recording and you will have access to those resources. So we do try to send our peeps to what we consider good information.
Mary Lou, there's a question about continuity of care and, handing off between providers in the setting of a long labor. So I can answer what our general practice is at Northwest. We tend to work 24-hour shifts. Occasionally there's a 12-hour shift in there. So you usually will have one midwife care for you for a full 24 hours, and then the oncoming midwife will take over at the end of that 24-hour period, or occasionally 12-hour period. So if your labor is longer than that time frame, it is possible to have more than one midwife caring for you during your experience. And I would say that theoretically that can sound like a really challenging thing, to have to switch who is with you. But I think that one of the things that I appreciate about our group is that we all have a very similar approach to care and to the experience that we hope to create for people. And I have gotten many feedback, or a lot of feedback, that it was actually a pretty seamless transition and different than people expected or anticipated in that way.
Yeah, I agree. And also, if your midwife's been with you all night, you probably want somebody who's fresh and clear-headed if you're having a long labor.
Yes. Bright-eyed and bushy-tailed.
To have that new midwife come in.
Yeah.
I remember myself having a long labor, and I said to my husband, if another midwife comes in and I'm still pregnant, I'm going to cry.
Did it happen? Did you cry?
Oh, I'm not sure at what point that was. I'm sure there were tears along the way. And we had a student a few years ago, or a couple of years ago, who did a survey of our patients and people who delivered with us, and mostly what they were saying is they felt we were interchangeable, and they liked seeing all of us. And I thought that was really nice. That we were complimented that people felt that way. And they also felt like when they saw a different midwife, we knew the story, because we have a good charting record keeping system, and we share information, and we have agreed upon protocols, so that we don't want it to be disjointed when you meet one midwife and then meet another midwife. And certainly you can choose to see only one midwife. You just have to know that that person may not be able to be at your birth. There's another one here about what's the general approach about requiring IVs and electronic fetal monitoring. I'd like to be unplugged as much as possible. Can I request that when I'm in the hospital?
I can speak for Mont Lake, absolutely. I mean, as long as you don't have any risk factors, which when we have a discussion, probably when we talk through your birth plan, if you don't need IV antibiotics for GBS, group beta strep, which we test for at the end of pregnancy, and you are low risk and healthy, then we certainly do not have to have an IV, and you can have intermittent monitoring.
And that's usually our go-to, is the intermittent monitoring. You come in, we do a tracing on the baby, and if the baby's doing well and you're low risk, intermittent monitoring is generally our preferred method, because it's less cumbersome. If you need continuous monitoring, the good news is we have cordless monitors. They can go in the tub, they can move around, so you don't have to be stuck in the bed. And even if you need that IV for the penicillin, it'll be run in and then capped off, so you're not tied to a line the whole time. So I think we're same at our location, Heather.
It's always our goal within the realms of safety to give back to you whatever power and control you can have during your birth process. And, you know, all things considered under the realm of safety, you know, if you have choices that are not necessarily the norm for what other people might have in their birth experience, we are absolutely open to that discussion.
This one says, are midwives more present in the room during labor than OBs? And I would say, you know, I'm generalizing, but yes, I think so. And certainly at our location, we're managing fewer patients at the same time. So we have a slightly smaller volume, so it's easier for us to be at the bedside. And we also don't schedule our clinic day the day after we have calls, so which a lot of OBs unfortunately have that situation. So so we can be more present, and certainly that's our I think we all like to be present at the bedside. Can't be there all the time, every minute, but when you're pushing, we're certainly in there most of the time. If you're needing us, we're certainly in there. And I would say in general, we're there more.
I would say that's part of how we, I think that's the connection to the evidence base of having different outcomes. We do spend a large portion of your labor at the bedside with you, actively engaged in that process, and we have a lot of understanding of how that process is going. And we spend a lot of time labor support and during the pushing process. So we really are hands-on and eyes-on very actively throughout your whole labor process.
And I think that's part of what allows us to be more hands-off, so to speak, is that being with people during labor and being able to take the pulse of a labor and see that it's unfolding in a way that is normal allows less intervention and is very helpful in providing care.
Yeah.
Lastly, I would just say no intervention can sometimes be an intervention, and there's a lot to be learned from just witnessing a woman as she births.
And there's so much information you gain from being there. You know, I think obstetricians are taught to, you know, come in and check the cervix and look at the data. And there's a lot that you gather from just being in the room and being with them and watching how a person's coping, how their support is, watching the rhythm of the contractions. I remember being taught that by a really good labor nurse when I was learning to be a nurse. It's just, you know, you just got to be there with people to see what's going on. So I think we have to wrap up. We could all talk about this all day.
I was going to say, guys, this has been an amazing conversation. Thank you so much. Mary Lou, I know you wanted to tease up some final slides, just going over our amazing panel today, where they're located, and as well as Mary Lou suggested during the conversation, a list of recommended resources that you can take advantage of. So
these locations were our two, so UW Medical Center has Northwest and Mont Lake, and Heather's part of the Mont Lake group, and the other three of us are part of the Northwest group. And here are some resources. So some of these are about childbirth, and if you're looking at considering a midwife, those are some good resources to check out. And we also included some things on childbirth, contraception, breastfeeding. If you're a patient of ours, you'll get a lot of resources.
this is wonderful. I just want to say thank you to everyone. This has been great conversation. Everyone who joined today, I hope you found value in this conversation. And as we said, it has been a live recording. We will be sending this out to you shortly. And we appreciate everyone participating today. Thank you so much, and take care.
Can I say one other thing? I apologize if we didn't get to your questions, and you can contact one of our clinics if you have questions that you'd still like to get answered.
Absolutely. Wonderful. Thank you.
Thank you.
Have a great day. Bye.
Bye now.